will be live in about 15 seconds. Thank you all again for coming. I really appreciate it. And I'll report to you when we're done. Okay.
All right. Welcome to today's Hinckley Forum. My name is Nahom Taddessa, and I will be the forum host for today's conversation. The Hinckley Institute of Politics is a nonpartisan institute at the University of Utah. The Hinckley provides an array of transformative experiences for students through internships, forums, and classes. Hinckley forums seek to foster public discourse and civil debate on the most current and pressing issues, bringing in local, national, and international thought leaders. We want to thank the Utah Public Health Association for helping organize this forum. Today we will be talking about social determinants of health, or SDOH, and we are excited to be joined by some great panelists. Riley Curtis received her undergraduate degree from the University of Utah, where she also received her master's degree in public policy. As the Director of Community Engagement at University of Utah Health, Riley is leading the hospital's healthcare anchor institution work, engaging with community-based organizations to address social determinants of health and building partnerships across the University of Utah campus, University of Utah health plans, and the university's hospital. Dr. Neil Davis is a pediatrician who has practiced at Hillcrest Pediatrics in Murray for over 10 years. He is currently the medical director for pediatric community-based care for Intermountain Health and has had various leadership opportunities, including 3 years of service on the board of trustees for Intermountain Health. He currently serves on the executive board for the Utah chapter of the American Academy of Pediatrics. His personal mission is to unleash the potential of every child. Lisa Nichols has 30 years of experience in nonprofit healthcare as the CEO of an FQHC and an administrator of Title X programs. As the current Assistant Vice President of Community Health for Intermountain Health, Lisa has leadership for the community healthcare community health portfolio, including Intermountain's work to address social needs and anchor initiatives. Lisa has also served as adjunct faculty at the University of Utah, teaching courses with a focus on underrepresented communities. Oretta Tupula has 25 years of experience in community outreach, advocacy, and health, working with underserved communities. Her love for community work started as a parent in the Head Start program and working with grassroots organizations. Oretta has a bachelor's in social work at Brigham Young University, Hawaii, and a master's degree in social work with a health concentration at the University of Hawaii, Manoa. She currently serves as a community healthcare coordinator with the Utah Public Health Association. Today's panel will be moderated by Bill Krim. Bill is the president and CEO of United Way of Salt Lake and has worked for nearly 30 years on issues related to economic opportunity, healthcare, education, and poverty. He also serves on the Governor's Education Excellence Commission and is a frequent speaker on topics of collective impact, pay for success, financing, and public advocacy. Please join me in welcoming our guests.
Thank you. I hope it's okay if I remove my mask while I do this. You'll hear me better. I'll be less hot. It'll be better for me. This is awesome to do this for a variety of reasons, but one is this is the first time that I've been in like a setting like this since COVID started, and it's fun. It's awesome. You may have noticed that in Lisa's bio and mine, there was a similar timeline to our lives. And at the beginning of we were here in the building's predecessor 30 years ago as students together, and it's fun to be here with Lisa and with everybody who I either know or am meeting for the first time, so welcome. So social determinants of health has become a much more common phrase and topic, and thank goodness for that. It's super important. And it's kind of a broad term. It might mean everything when you say that to somebody. So I want to turn to Dr. Davis first and ask you to articulate sort of the big idea of social determinants of health from the perspective of a patient and a doctor. What's the big idea about social determinants?
Sure. So I think the idea of social determinants of health has been around for hundreds of years. One of my favorite books is Les Miserables, and in the unabridged version, Victor Hugo talks about it, in my opinion. He talks about it related to children and how it is such a tragedy that so many children don't have the opportunity. And he writes in it's in the unabridged version, so you have to kind of wade through a lot of sewers and other things. But he talks about how many Galileos are out there and we don't know. And he goes on and he talks about the circumstances of people and how that impacts the ability to unleash their potential. And health is directly related to that. I would say it's been over the past decade, probably fair, that the medical field has finally awakened to that. Been kind of slow to the game. Other fields have been there for quite a long time. At some level, this is common sense, right? I mean, the circumstances that we have socially have massive impact on our health and our wellness over time. And we know that starts very early, and that's, I'm a pediatrician, so these things start even before birth, and in the early years of a child are very critical to unleashing the potential of that child. And so factors such as poverty, education, the list goes on, different connections to resources and opportunities greatly impact a person's ability to have health and wellness, access to food, access to healthcare, all of these things. The list is very long. And thankfully, over the past decade, the medical field at large is starting to awaken and start to really think about that. I don't know if that was more than you wanted to know.
Yeah, no, that was great. That was great. It prompts me to want to hope that one of you knows a statistic that I don't recall exactly. But the medical field has calculated the cost of these social determinants relative to the cost of actual medical care. Does anybody know off the top of their head the ratio of total costs?
I can mention a study, and Lisa knows this, well, probably everybody knows this data. There have been some really meaningful studies about the past decade, and one that came out in the New England Journal of Medicine a bit ago said, okay, if we take a look at what does health look like, what percent of our general health overall is actually related to health care? Turns out that's like 10%. Mm-hmm. And our social and environmental factors, I think, was hitting around 30-ish. Mm-hmm. Does that sound right, 30%?
Yeah,
there are other factors like genetics and so forth, but go ahead.
Behavioral. Lisa. If you include sort of the conditions in which people live, like housing, et cetera, and then also include personal behaviors, things like whether or not someone exercises and eats healthy foods, and those things are often really related to your social conditions as well. You can get up to 60% of your health is really contributed to by the environment. And then Bill, I don't know the numbers, but I think what you're looking for is that there are graphs and studies around where the United States puts their healthcare dollars, which is largely into that 10% of healthcare delivery versus into social services, which is something that a lot of other countries do. So I think, while I don't know the dollars, really, the sentiment is that we've mismatched our spending with what contributes to health and well-being.
So Lisa and I were joking that neither one of us prepared a PowerPoint today, but imagine you were looking at a couple of charts, and one chart says the bulk of the impact on a person's health comes from these social and environmental factors and behaviors. The bulk of the money that we spend on healthcare goes into the smallest, the least amount of impact on our health outcomes. And then the third chart would show you how are we doing in terms of healthcare. And I'll just sort of play panelist for a second and say, relative to other countries, we're not great.
Relative to other developed countries, we are not great in our health outcomes and our health access. Yeah.
So the topic of social determinants of health is about solving those problems, those interrelated problems. Loretta, I want to turn to you and see if you might be able to sort of help us put a clearer face on the challenge that any of us might experience. You work with a lot of families who are trying to navigate a complicated healthcare system that generally does not, and an overall sort of economic and social system that doesn't incentivize and pay for the right things. How does that show up in people's lives?
I think that exact picture that we had just talked about, that's how it shows up. I mean, well, we're helping the most underserved communities who are impacted by these social determinants try to access the system where the barriers are so impossible that they can't get healthier. They can't. So it's showing up where for families that are on a lot of social programs who are needing a lot of resources and help, but like you said, there's no funding going into social programs or social services, and so there's just an imbalance. And these families are the families that have the least access because of transportation, because of housing issues, because of food access, and so trying to, as a community health worker, trying to help them access those resources with all these barriers and with all these, funding issues, which is the hugest barrier for me, has been almost impossible. And so we've had to look for loopholes in the system, look for ways to, charity even, pathways to help these families, and it's not helping us as a whole society. And so it's kind of why we are pushing on the policy end. Like, we need to really look at where we're spending this money because of the imbalance in spending as far as healthcare and social determinants go. And so the families that we're serving are the ones you're seeing in the emergency rooms all the time instead of accessing primary care. And those dollars even, I mean, it's huge. The cost for emergency room care is huge. And so, but that's how they're showing up.
Yeah. Riley and Lisa, I'm going to ask you in a minute to talk about how your healthcare systems have been trying to tackle this. But my guess is that maybe some folks in the room and online have not heard of community health workers before. You know what a doctor or a pediatrician does. You know what a United Way person does. You might know what somebody who works for a healthcare system does. What is a community health worker, Oretta?
Yeah, community health workers are frontline public health workers. They represent the communities that they serve, and they really work on the social determinants of health, those barriers, helping communities access resources that have that they haven't been able to access. So they do language interpretation. They can do they take community members to their appointments. They do home visits. It's a lot of the non-clinical work that you can do with a community outside of the hospital or the exam room. And so really that just those front responders, you've seen them probably or met them during COVID especially. The pandemic has brought a lot of CHWs out to do testing clinics in the community and vaccine clinics and just a lot of health promotion for communities who have hard access to resources.
Yeah. I'm going to sort of make an observation about this. Like, we live in a world where you could Google, like if you had a need and you recognize that, you could Google anything. But I personally would not Google and then like health specific things and try to navigate the healthcare system just with Google, especially if I were new to the country, especially if I didn't have health insurance, like if I had economic challenges or anything. So like, thank heavens for community health workers, because it's like having somebody you can call and say, like, help me navigate this world. There are 10,000 different social service programs in Utah. Like, imagine trying to navigate that. Now, thankfully, I'm going to put in a plug for, like, there is a mechanism to try to make that simpler called 211. United Way of Salt Lake operates a service called 211 where we curate that database of 10,000 services and we try to help folks navigate that. But it's not adequate without a community health worker. And so trying to sort of make some sort of sense out of what a professor at Harvard Business School called service delivery chaos for people is part of the social determinants story. The University of Utah and Intermountain Health have both done things over the last couple of years to try to link the provision of healthcare and the interface that healthcare providers have with this service delivery chaos. And Riley, if we could start with you, like, talk about what you've done, what you've learned, and then Lisa will go to you for the same thing.
Sure. Thank you. So there's so much. I think some of the programs that we've done, I'll name a few and give some overview of the successes that we've seen. But the biggest one that we have is with our College of Nursing and our emergency department. So they received a grant. Andrea Wallace is the one who runs that program. And essentially, they have created their own screening question. It's a set of 10 questions. They offer it in Spanish and English. And as somebody comes into the emergency department, they're screened for social needs. And you can imagine it's like food, housing, transportation, those types of things. And so I have my statistics here. So since 2019, we've had about 21,000 patients screened in that manner. And about 33% of those patients have at least one social determinant of health need. And of those, we have a partnership with United Way 211, where we have FTE on their full-time employees on their staff that will call those patients that have identified those needs. So instead of historically what you see providers do, because we're so busy, right, is we'll just print a list or we'll say, call this number. And it's very cold. And what we know and we've learned over the years is that you need this warm handoff, right? Like you need a voice on the other end of the line. You need somebody that's going to hold that hand and help that patient. So that's the program there. And we've started tracking, I'll just give you a statistic over the last year. They have about 23% success rate of reaching 211, reaching those patients. So that's not since the inception of the program, but they're really trying to actively work at getting that success rate higher. But again, it's the need is there, right? Like 33% of those patients screened are having a need. And then we also have another program called the Intensive Outpatient Clinic. And this is a clinic that was funded by our University of Utah Health Plans, which operates like Medicaid and Marketplace programs. And so they've taken the highest cost Medicaid patients that go to the emergency room, essentially as their primary care provider, and really put an entire care team around them. So they only serve 230 patients. They're the highest cost patients, and they have seen about a 77% reduction in emergency room visits by putting an entire clinical care team behind them. It's not just clinical. So if you think about a room and there's a table in the middle, you have your social worker, you have your community health worker, your medical provider, and your administrative assistant all in one room, and your therapist, who have just seen that patient, and they can talk to them and say, hey, this patient just got done in their therapy session. They said they had a question about their medication. When you see them in 5 minutes, can you answer this question for them? And it's intensive, right? So 77% reduction in ED visits, 50% reduction in total medical costs, and 30% reduction in hospital costs. But at the end of the day, like the statistic that really matters is the improved patient perception of their healthcare, right? Their depression rates are going down. They're saying in general health they're feeling better. They're reconnecting with family, and it's been a wonderful program. So it's finding those ways, Bill, that we can kind of like build those programs. That may not work for the entire medical system, right? When you're seeing thousands of patients, but what can we do for those patients that we do see this need exists for? And how can we build on those models and ultimately get to value-based care where we want to pay for the value outcome, not just volume?
Awesome. Those are exciting. Lisa, go ahead.
All right. Well, let me maybe share a little bit about how we think about this and then give some specific examples. So our mission at Intermountain Healthcare is helping people live the healthiest lives possible. So that mission, you'll note, is not about providing excellent healthcare. It is. We certainly provide excellent healthcare every day, but it's a comprehensive view of the individual and the things that contribute to their health. So when we look if we think about how to influence health, we think about the individual social needs that people are experiencing, and then we also think about the community infrastructure and what is the environment that contributes to poor health or excellent health and well-being. So, similar to Riley, Intermountain has put together initiatives where we screen people for social needs. We have a significant demonstration project that just closed out at the end of last year called the Alliance for the Determinants of Health. And in 2 communities, Weber and Washington counties, we brought together a lot of community partners, the federally qualified health centers, the local mental health authorities, the police departments, the school districts. And we collaborated with them to screen people for their social needs. So to say, in your medical visit, do you have food in your house? Do your utilities work? We found there are 100 people in Ogden where I live who don't have running water. Right? I mean, that might be surprising, but I think it's actually not uncommon. We find lots of people who we're sending to food banks, but they actually don't have a fridge or any way to prepare their food. So to ask those questions and really get to people's needs. Loretta talked about community health workers. It's so important then to connect them to a community health worker, help them navigate the system. So we've been doing that in 2 communities and have supported about 10,000 people in meeting those individual social needs. And we're in the midst of a significant independent evaluation initiative to look at how that worked out, both in terms of health outcomes and caregiver, medical provider satisfaction. Right? That's important as is patient satisfaction. We also, we have used 211 and we've used Unite Us. I see them here in the audience where what we do is try to connect healthcare to social services, right? I mean, if you go to a medical provider and you get an x-ray, that x-ray is digitally available to other medical providers so that they can provide comprehensive care. We want to have that same kind of communication with social care, so that if we send someone to the food bank, we can close the loop. We know if they've come. We may hear, gosh, they don't have a fridge, right? So that's a need that we can address. So we've really used the data to understand kind of, what are the gaps in the community infrastructure? And sometimes those are political, right? We really work in this political space. An example, we had a woman we were serving in Washington County, and she was seriously mentally ill, had very complex medical needs, had become estranged from her family. She was living in her car, and her head is nodding because it's not an unusual situation, but she had a housing voucher, right? She had a resource. And what was standing between her and taking advantage of that resource was $25 she had to have for a criminal background check to have the housing. Now, probably any of us would give her that, but there's not a mechanism to do it. And in fact, there are legal prohibitions against health systems giving individuals funding for those things because that can induce care. So we want to understand those political issues and address those. And then we want to understand, what's happening in the community infrastructure. And we find overwhelmingly it's housing, it's transportation, and it's food infrastructure. So, Riley and I both work on what we call anchor work, which is really looking at what are the assets of a health system beyond their health care delivery. What can they contribute to the community to increase well-being? So we have an impact investing program. To date, we've invested in almost 1,100 units of affordable housing, right? So it's one thing to really think about what are those individual social needs of someone, but I think we've all been frustrated because housing comes to the top and we say, sorry, we know there's not enough housing, there's not enough affordable housing. So we want to understand the individual needs, address the individual needs when we can, but really understand, what's happening in the political environment, in the community infrastructure. How do we get further upstream and really transform the system of care and the places in which people live?
I want to come back to that big question about politics and policy and the decisions we make. But first, Dr. Davis, as a doctor, or maybe on behalf of caregivers, how have you experienced this? Maybe it's a wonderful thing, maybe it's an added burden in our current system to screen people and then try to help them get started on the path to getting those social care needs met.
Yeah, great question. I'm going to be very biased in my answer because this is my passion in medicine, so let's put that out there. But so in my office, we've been working on a model of screening for social determinants of health and psychosocial needs for a child and their family for about a decade. And it's a model that was developed in Baltimore, and it is something that we do from birth up to age 5. And then we have a system beyond age 5 too, but being able to do basic screening for these things that we've talked about. But for a child, there are other things too. There's the mental health of the parents. There's potential intimate partner violence in the home. That there are issues that really impact health. So it's really more of a psychosocial issue. And the model that we use was shown in really good studies, randomized controlled trials, to reduce reports to Child Protective Services by nearly a half, and also decrease severe abuse of children in a similar way. So when you think about what that means, that's really big. It doesn't mean we can fix everything. I'm not implying that by any means. But if we sincerely approach people and meet them where they're at and respect them and offer things that might be useful, it can literally reduce child abuse. I mean, that's a big deal. Yeah. And so I think for providers, training matters, Bill. So when we do this, when we roll this out, so we rolled this out across all pediatric offices within Intermountain and family medicine and others who we're working through that. But training matters. Helping people to understand the nature of the need and to understand the basics of the resources. And then most importantly, I think a really critical piece to this is how you talk with someone about it. There's something called motivational interviewing. I don't know if many of you have learned about that. The short version of that is just being respectful and listening a lot. That's, you've just learned motivational interviewing. But the really important point, what I have really learned, when I first started this, I thought, oh, we're going to help so many people. The word help is even a little misplaced, in my opinion. We identify things, and we have conversations, and we try to be useful to support people, because these are remarkably resilient people. Yeah. Like some of my patients and their families, they have the highest needs, are among the most resourceful and creative people that I know. Yeah. And I think when providers actually understand that, it makes it more effective, and it also lifts some of that burden as well, because you realize this is something we're working on together. So those are some of my thoughts, Bill.
Awesome. Yeah. Loretta, in your work, how do you navigate this complex system that we're talking about? How do you interface with healthcare providers?
Yeah, I'm actually getting so excited I can't sit in my seat because we're doing a program at the University of Utah with the School of Medicine. We're working with providers who are in school or going out into internship to just talk about cultural humility and about how to work with underserved populations. And they have a lot of questions, but the answer really is what Dr. Davis just shared. It's just having that empathy and knowing that and being present in the exam room. The families build that trust with you, and then they're more compliant than not when they know that they can trust you're looking out for their best interest. But what I was hearing a lot here too is for community health work, which is why I fell in love with it, is as a social worker in my background, it's a place for me to combine these two worlds who have been so siloed in the regular medical model, and just looking at diagnosis and treatment, and bringing in this social piece and using this ecological model of looking at patients in the context of their environment and how all of that impacts them and their health. And that's what we can do outside of the clinic. And there's a lot of territorial things going on with, professions about, that's what I do and that's what I do. But the truth of the matter is we are so burnt out. Our health professionals are burnt out. There's so much work. The complex needs of these community members, they're so specific to the patient. And so you can't navigate all of that. And we try to share with the providers, we're not trying to take away anything that you're doing in the exam room, but with the patient-centered medical home model, which is kind of what you were sharing, just doing all the social assessments and all of that, that's something we can take. There are some things that we can take as community health workers so that the nurses, the providers, the social workers can maximize their expertise and use in the clinics and do what they do best. And so that's what I love about what we can do as community health workers, is bridging those two pieces together, because that's really what it is. I mean, it's looking at a person in a holistic perspective rather than just the treatment or just the housing need or just the transportation need.
Yeah. So there are a couple themes I want to dig into before we get maybe to the policy questions, which we will do for sure. But the idea of listening to people, respecting their experience, their lived experience, and listening to them is sometimes lost in traditional policymaking conversations. Often, I might say, lost in that. In your experiences, so this is a question for everybody, we'll just go down, maybe start with you, Lisa, but in your experiences, what would people who are facing these challenges that we're talking about, what would they say if we did ask them, how can we address it? My guess is saying, how can I help you with the social determinants of health is not the question.
Yeah.
But if we listen enough for the right things, what would people be saying about what needs to happen and what enables them to be healthier, to have their needs met, et cetera?
Yeah, it's such a good and huge question, Bill. We actually asked that before we started the Alliance. We did an ethnographic study where we went into people's homes and spent 4 to 5 hours with them, saying, just tell us about your life. Show us what's important to you. Show us your cupboards. Show us what's in your fridge. And we learned a couple of things, probably not surprising. One is that people don't necessarily think they have social needs, right? So their cupboards might be empty, but when you're asking them, are you hungry and do you know where your next meal is coming from, they're not expressing that. Right? So, so that can be challenging, right? We learned about people's social support, right? They would show us, I was not there, but I'm relating it, show pictures of their children and their family, and you can see in someone's home what's important to them. And really, learned about this resiliency that Dr. Davis is talking about, and that individuals whom, from our perspective, we thought were really going to thrive, often had really high social support, and individuals who we thought were going to really struggle were more isolated. So I think I see the community health worker role as being a navigator, but also often a social support and a friend. And I think, we also learn, we have this kind of wheel of how we look at social needs, and there's so many of them, right? Your utilities don't work, you don't have stable housing, you're not safe in your home. Educational attainment is not what you want, you don't have an income, et cetera, et cetera, et cetera. And so many individuals would have multiple needs in each of those areas. And that can be really overwhelming and burdensome to the individual and really overwhelming to a health system. Like, where do we start? So we heard from people, what Neil has just said, meet us where we are. Understand what is most important to us. Help us figure out what is the best next thing we can do, because we can't do all of it. So what's sort of the next step in getting what I want in my life?
That was so well put. I was just going to pull from a couple examples from our work as well. So, with the intensive outpatient clinic, there's a video that Nick, I think, is going to share that's online, but it's about the intensive outpatient clinic, and it follows one individual that was helped. And one of my favorite phrases from the staff that work there is that we come from a place of trauma-informed care, right? Especially in that clinic, and hopefully that's permeating throughout all of healthcare, but especially there. And instead of asking what's wrong with you, we ask what happened to you, right? It's coming. What are the social factors? And this patient, he goes all the way back to, my mom died when I was really young, right? And that's where a lot of these issues start, or these experiences start that just domino effect. But I want to come at it from a different perspective of two projects that I'm involved with. One is in Glendale and Poplar Grove area, and the other is in West Valley. And we're looking at a community level, what can we do to partner with these communities, right? I think there's a lot from healthcare, and especially like where we're located on the Hill, right? It's like we come down as researchers and as this big institution and say, we know exactly what's wrong with this community, and this is what you need to do. And we don't ask the community, what are your strengths? What are assets within your community? And I think that's where community health workers have really helped open the eyes of local health departments, of the state Department of Health, of hospital systems, especially during COVID, that we need to be partnering with community way more to address these needs. We need to listen, we need to ask questions, and we need to understand that they're not always coming at this place, right? Like you said, well, I don't know that I have a social need, because they're not thinking, they're just living in it every day, and they have assets, right, that we can tap into, social networks, community resources, and by us not even understanding that, we come off as the ivory tower on the hill thing. And that is why people feel disconnected with healthcare and what we're trying to do. And so I think I've said this already, but it just comes back to listening.
I think that's true. I was thinking about how do I answer that question, and I thought maybe the best way for me to do that is kind of trace back some of my patients in my mind and kind of where they're at now and where they've been over the past several years. Because if I ask them what the global needs are, I don't know, but I do know for some of these families, there have been certain times where they have needed housing and have needed support for significant housing insecurity or the homeless shelter, other times food, other times transportation. Right now with this one family, doing pretty well with housing and food and transportation. And now mom needs support she would like support for daycare for her little baby. That would be the most useful thing for her to be able to get back to work, which is what she wants to do. Another family with school, their housing is more stable now, but the kids are they need more support for their school and connections to schooling that's really going to help them. I don't know. For me, it's a longitudinal thing, I guess, over time. Still struggling with that question, Bill.
Those are all good answers, real challenges. Loretta.
Yeah, I think the expected answer would be like they're sharing for a macro level to come down to community and talk to them about what they need. But for me, my perspective, looking at how we address social determinants of health, it's really not for me what they would say if I asked them, but who's saying it. Because a lot of times, our community members have felt like tokens on a committee because they're just there to represent, but don't have a real voice, don't really have authority to make a decision in what's being, discussed. And for me, the ask that we're giving is that we're involved in these decisions on a different level. Before you plan the project, before you implement, before you do a survey, bring us into the conversation. And when I say not what they say, but who says it, I can ask any community member who's Polynesian, hey, I need a Polynesian person to represent this community. Can you, a friend or whatever. There's a difference between asking that person and someone who has like a CHW who has been experienced in the field, who also experienced and lived the experience, but understands the system and what they're looking for when they ask, what is it that you need? How can I best help you? Because like you said, they don't know. I mean, one thing like you said, I agree with is that for a lot of our community members, we know how to survive. So if you ask me if I need something, I might say no, and my cupboard is bare, but it's because I know where I'm gonna get the food for tonight for my kids to eat. And so it's not something that I need right now. And so for me, that's, I think, what's important is who's saying it, who's at the table, and that we're there from the very beginning versus like when someone's gonna do a project or someone's trying to address one thing, because there's so many different things that they need.
I guess I wanna add, it's so much more than 10 questions in a screening room, right?
Yeah.
And that's what I think we're all grappling with, like trying to figure out what's the right way. And like, as I'm listening to Areta, like it's, we're really trying to focus, and we're struggling with this reckoning of like systemic racism, right? And how do health systems who have historically locked people of color out of medical schools, how do you, as like a person of color, want to receive your care, and how are you going to receive those questions, right? Are you going to open up more to a provider that looks like you or can ask you the question in Spanish, versus somebody who is white and is like thinking about the next 5 patients. And I don't mean to say that that's because Dr. Davis is obviously like very passionate about this, and so are like so many of our providers, but it's something as systems we have to reckon with. And it has taken a long time for them to even listen to these concerns. And I think we're getting to a point where now we're starting to understand, how do we start to formulate plans to address these concerns?
I'm glad you brought that up. The Utah Hospital Association, of which you're both a part, has actually said that out loud in a policy environment, like, we have to address these systemic challenges, right?
Yeah.
Yes.
Let's imagine for a minute, we're gonna get to questions in 4 minutes. Let's imagine that we've developed relationships, we've listened. You've all described the way in which we might address the social determinants as something that requires a pretty high degree of teamwork across systems and sectors and programs. I wonder if we could ask each of you to just say, what's one enabler of that teamwork, or what's one barrier to that teamwork that needs to be addressed? We'll go with whoever's ready
I'll
first.
jump in.
Dr. Davis.
So I think one of the things about, at least with medical providers, are very hesitant, I think, at first to jump in. And I think it's wise to be thoughtful about the resources. If you're going to ask these questions, you're going to have these conversations, you need to think about that. Having said that, I'm a huge fan of perfect is the enemy of the good. Okay? We can wait for perfect so long that nothing ever happens. And I think it's really important just to lean in and ask the questions and be able to listen and be present with people to navigate things. So Bill, gosh, I got lost in that. What was the original question?
I think you answered it. You said act. Like, don't wait for perfection.
Okay.
Act and improve.
Yeah,
Yeah. In an environment of listening.
there you go.
Loretta?
I think enablers, I don't know, I'm just grateful to be able to even have this conversation with all of them. I know that we're in a lot of meetings together, so they get it and they understand. You know, I think, like Riley said, a couple of years ago, you couldn't even have this conversation. You couldn't bring up, you know, how is it that we can help you without saying, you know, something was wrong with my system. But now to have these open conversations, it's been huge. And so that barrier to me was the biggest, and now we're able to have that.
Awesome. Riley or Lisa?
Not to keep making this political, but I feel like an enabler for us, or where I've seen a lot of momentum come around this, has been with the murder of George Floyd and with COVID happening right at the same or near the same time points, right? And you know, you heard a lot of conversations about social determinants of health over the last 10 years, but for us, it really became real when we saw the disparities, the health disparities with COVID testing, COVID vaccination rates. And then we did this public statement on racism as a public health crisis, recognizing that there's a need. And when we look at our hospital administration teams and facilities, it's very Caucasian, right? It's very white. And how can we who are we to say what we need to do to help to best serve this population, right? It's having more diverse voices in the room, it's more conversations, but I would say that those were 2 very big catalysts for why we're able to have these conversations now.
Yeah, I agree. The pandemic has been good for us in some ways.
Yeah.
But
If there's one positive outcome.
but I'll take it somewhere else, which is really the work that Intermountain has done, and then overlay the pandemic on top of it, has driven collaboration in an entirely different way. Right? I mean, our work is very much driven by the communities we're in. We have local steering committees. Intermountain actually doesn't even have votes on those steering committees. We sit in the room. But we have shared dashboards. We meet regularly. So I think sort of building, like Loretta, you're saying, to have us here together, building the relationships and strengthening the network that serves people comprehensively, not the network that serves people socially, the network that serves health, but to bring them together, and to bring them together in really actionable ways where they can see their progress has been really important for us.
Awesome. Okay, heads up, all of you. It's question time. Noam, we're going to have you do what you do to find the questions. And then here's the tee up for your last question. We'll get to the policy question. So, and I want to share a story. So I co-chair a group on behalf of Governor Cox to think about and talk about and design, some kind of strategy to address social determinants of health using a technology infrastructure. So one enabler of better teamwork is better technology. I'll just put that out there.
Yeah.
In our conversation about better technology, a community member who often has to navigate this system said very clearly and with tons of courage, you people are kidding me. If you think technology is my biggest problem, I don't need a better software tool. I need policies and practices to change. So your last question will be, if you could change one policy or practice in any of the systems that interplay with this, what would it be? Think about that. We'll come back to you in 10 minutes. And,
All right, questions. If you have a question, please raise your hand.
Hello, my name is Melody Sadri. I'm a Master's of Healthcare Administration student here, and my question for y'all is, you mentioned that there are legal restrictions in giving patients funding for those external services like the background check. So I was wondering, are there ways to get around those legal restrictions or even the bureaucratic system that is healthcare in order to mitigate those financial barriers?
Yeah, there are two sort of broad legal concerns. One is around inducement, right? So, neither health system can be seen as offering a patient something that would induce them into selecting us as a health plan or as a health system, and the restrictions on that are $75. And then there are anti-kickback statutes, which really are protective, but they sometimes get in the way of collaboration, right? So we can't do anything that makes it seem like we're driving referral patterns in a particular way. So they're good and they're really problematic. And I think, we would love to see them sort of addressed kind of at that root cause level, but there are all kinds of ways to get around it. So one of the things that Intermountain has done in collaboration with the Department of Health and also separately is we've created a discretionary fund that's managed by the Association for Utah Community Health. So we make a charitable contribution to them. They can then address someone's social needs. And give an example, we had a gentleman who was who was homebound. He had some medical equipment that was very expensive. It was like $23,000, and it had to be replaced 3 times. And when we sent a community health worker in, we discovered that there was a bug infestation in that equipment. So for the cost of bug infestation, which is like $100, you save $75,000. Right? So we create that discretionary fund. Community health workers can, they have the authority, right? They see the need, and they can access those discretionary funds and meet the person's need.
Thank you.
Yeah.
So you were talking about multiple social support systems being used and navigating those systems. Are most of those systems private? For social support organizations?
No, there's a lot of community-based organizations who are helping who employ CHWs or have volunteer CHWs that help also in this work.
Yeah. Okay, so I was wondering, with the idea of universal health care, could there be a possible universal social support network? Or would that be a completely different thing?
It's possible, yes. It happens in other countries.
Yep.
Right? Think about Scandinavia, for example.
Yep.
Thank you.
you might, I'll just offer, of all the kinds of social care needs that are out there, you don't have to have a single system for all of them. You could break them up, and you could tackle things like transportation as a universal challenge, or you could tackle childcare as a universal challenge.
Well, great panel. It's so great to hear from you guys. I want to pose a question because most of you are representing health systems. When we have this, determinants of health, and we're thinking about who's going to champion this effort, what are you guys' views on that long term? Is it the responsibility of the health systems, or whose responsibility is it, and what role should we play? And I think Oretta, like your viewpoint too, looking from the outside towards the health system is also great. So I'd love to hear you guys' insights on that.
Yes. I see it as bigger and more complex than any single system. Sometimes health systems have more resources to convene people, but it has to be a really collaborative approach, right? We're never going to be the experts in housing or education. So for whatever convening partner, often it's United Way, right, can bring people to the table in this collective impact approach that Bill talks about and talk about, leverage one another's resources and do it in a really collaborative way. So I don't think it's our, responsibility isn't the right word. It's not our role, but we can get the conversation started.
Yeah, and again, well said, Lisa. I guess, and I've been very appreciative of Governor Cox and his efforts in his One Utah roadmap to head-on address social determinants of health. And while it started, I think, very big on what we could accomplish, it's now narrowed down into this project that Bill has kind of talked about. But my hope, and I'm a forever optimist, is that you get one problem solved or one project done and you can move on to the next thing. But the infrastructure has been built with the help of United Way to bring all of these players together and have that collective impact.
I'll jump in with just a specific example. I think how this intersects. There's an outstanding, maybe the best that I'm aware of, intervention for early childhood to change the trajectory of health and wellness for a child. It's called Nurse-Family Partnership. It was developed several decades ago. It's gone across the nation and the world. And it used to be in Utah. And when I first came here, I learned about it from one of my patients when I was talking about some of their social needs and just talking through things. And they had this nurse that visits the home, and it literally changes the trajectory of health. So we built out some opportunities to connect with this system that was funded federally. It flowed through the state, and we were able to connect in by discussing about it. Well, after a few years of some really awesome success, policies changed at the federal level, the funding disappeared, and the program was slashed here in Utah, which killed me. And so one of the opportunities that I have now is we're working with Primary Children's and the philanthropy that's going on there to be able to bring this program back, connect it into the existing community resources so it's not siloed, with a clear strategy, though, that we can't be the end of funding this. I mean, these types of high-impact programs, they are expensive, and they literally change lives. So our strategy is to get that going solidly in a sustainable way and create a strategy to influence the state. Because ultimately, this has got to be a partnership with the state, and it would be nice if federal would be more consistent, but they're not. But being able to create a sustainable mechanism of connecting with the state. So I don't know, it didn't directly answer your question, but it's a specific test case, I think.
Yeah.
Yeah, I think, like everyone said, it has to be a collective effort, and depending on what it is, that determines who you partner with and work on these different things. But one of the things that I love that you said, because that's what happens to us all the time, is CHWs are funded by grants, and so we get to help a community, and we're seeing positive outcomes, and then the funding goes away, and okay, I'm not doing diabetes anymore, but if you have cancer, I can help you with that. And it leaves patients, in a worse place, pretty much. And so, depending, I think, on what it is, you have to do this as a collective, and the partnerships have to be solid. But one of the things that I don't like about now that we're talking and coming together is that sometimes we will, in the systems, will see a problem and say, okay, we have to address this, and then we start developing new programs or our own partners when there are already existing partners who have been working on this for a long time. For me, it'd be more effective if we go and find those partners that have been doing it and use, work with them instead of create my own program and do it all over again, same thing.
Yeah. I just want to, yes. The role of a health system is never to compete with existing resources. Yeah.
That rule, you should write that down. Spread it throughout your lives. Don't start new stuff. It doesn't help. Like, align, focus, and improve that. So any last questions? Yes.
Hi, I just, again, kind of mirroring what he said, a lot of what we've been talking about today is, administrative roles coming down, like how we can help these underserved communities, right? But do you have any examples of community members helping each other find these resources, and how effective is that? Is it more effective to have other community members helping each other, or have you seen better success in administrative roles coming in and being like, here are your resources that you have available to you?
I think I can answer that. Like was mentioned already, our community members have their own strengths to navigate things. I mean, that's how we've survived for so long. But these partnerships are really important on every level, micro, meso, and macro, because there are a lot of things that we can't do. We can only do so much on a community level. The strength of community health workers is that we leverage all of those strengths we find who those community champions are, because the resources that we talk about when we say resource, it's not like, oh, the Department of Housing has, services that they can provide to help you with housing issues. It's the resource of who in the community do you go to find out things about housing. Once we start to identify who those people are, they become those community resources that we can say, because we can't do everything. I mean, that's the other thing. Everyone now is saying, oh, give it to the CHWs, they can do it. We're not miracle workers either. And so we have to use what we have as well to help us in our work. And we use the community members in those communities and find out, so that people actually go to the Relief Society president, or they go to their pastor, or they go to the neighbor who she's been through welfare and she knows what it's like to navigate that system. That's the resource that I'm talking about when I say that. And so it's not a like one level thing. I think the partnerships is what's so important in helping community members.
That would be an awesome place to stop. And this is the Hinckley Institute of Politics. We need to talk about policy. So in less than 3 minutes, let's start with you, Lisa.
Okay.
One policy or practice that we could change that would improve what we've been talking about.
Yeah, well, I'm going to go to practice, Bill. And I mean, there's so many policies, but I think much of what we do as a health system has been baked into years of systemic racism and evolving views of health. And so I think one practice you can do in whatever organization you are in, require that policies get reviewed with an eye to equity, with an eye to a very comprehensive definition of what well-being is. Doesn't matter whether you work in healthcare. Every employer influences health for their employees. So demand that your own internal policies are reviewed.
Awesome.
I'm going to go with working towards building a healthcare workforce that looks more like the communities that they're serving. And there are different things that we could do to address those, like looking, and again, it's coming at things from an equity lens, right? Like, who are writing the tests for our MCATs and for our social work students to become, do people who English is their second language, are they able to pass that? And we have statistics in Utah that show that they're not. They're usually like 1 or 2 questions away from passing those exams. And that's continually perpetuating this workforce that doesn't reflect the community we're serving. It's building partnerships with high schools and junior highs and in communities that maybe we historically haven't worked with. So those would be my recommendations.
Awesome. Dr. Davis.
There's a list, but we won't do that. I think as a pediatrician, my heart is always going to be in the early childhood space and having sustainable funding that partners with the community. I think the points you brought out are really good. So I'll leave it there.
Awesome. Loretta, the last word.
I'm just going to say ditto to what they said. Because really that's what we're looking at from the community level, is those opportunities to provide feedback about the policies and how they can be more equitable for community members. So, yeah.
Awesome. Let's thank the panel. Super smart, super brilliant. And thanks to the Hinckley Institute for putting this on. It's been great.
Thank you all, and there's pizza outside, so thank you.
Did they offer pizza when we were students here? No.